Hey everyone, and welcome. Today we're taking a really structured, incredibly important journey through pediatric neurology and emergencies in this explainer. We're going to move all the way from common, everyday clinical complaints to absolute life or death scenarios where literally every single second counts. So think about this for a second. What actually separates an everyday headache from a true drop-everything neurological emergency? It's a completely critical triage question. Headaches are the most common complaint in pediatric neurology, right? But how do you know when it's just stress from school and when it's a massive red flag? Getting this right basically sets the stakes for everything we're going to cover today. Here's our roadmap. We'll start by decoding pediatric headaches. Then we'll learn exactly how to spot red flags using the Snoop 4Y criteria. From there, we'll completely switch gears and bridge the gap into sudden trauma by exploring drowning, which is a true respiratory emergency. And finally, we'll lock down our absolute resuscitation priorities. All right, let's jump right in. Part 1, decoding pediatric headaches. First things first, we need to talk about primary headaches. These arise from the activation of pain receptors right there in the head. It's not from another underlying disease, okay? They are fundamentally disorders of brain function. Some kids just have pain receptors that are way more sensitive, making them so much more susceptible to these episodes. The big takeaway? It's not a symptom of a brain tumor or an infection. The headache itself is the primary issue here. Now, when we break down the two most common primary headaches, migraines versus tension-type headaches, you'll see they are completely different beasts. Migraines, they have a neurovascular and often genetic root. They literally run in families. They unfold in stages, sometimes over days, with auras, severe pulsing pain, the whole shebang. Tension headaches, on the other hand, are musculoskeletal. They're caused by tight muscles in the head, neck, or shoulders, usually triggered by stress or terrible posture. A tension headache might be annoying, but a migraine, that can literally stop a kid in their tracks. Okay, please pay close attention to this next point because it's an absolutely crucial clinical insight. In young children, migraines often do not look like adult migraines at all. A young child might not even complain of classic head pain. Instead, their migraine can show up as predictable, cyclical vomiting or recurring abdominal pain on a set schedule. If you're only looking for a kid holding their throbbing head, you are going to completely miss this diagnosis. So what actually brings these primary headaches on? Well, we're mostly looking at really common everyday lifestyle triggers. We're talking poor sleep, dehydration, skipping meals, high stress, maybe way too much caffeine, and poor posture. I mean, just think about kids hunched over their tablets or phones all day long. The good news here is that these are triggers that patients and parents can actively manage once they know what to look for. But hold on, here is a massive trap. Using acute pain meds like ibuprofen more than 2 to 3 days per week can paradoxically worsen headache frequency and severity. This is what we call medication overuse headache. And it is such an easy trap for well-meaning parents to fall into, right? They see their kid in pain, they give them medicine, it helps a bit, so they just keep giving it. But by doing that too often, they're actually making the underlying headache disorder worse. Educating families on these medication limits is absolutely crucial. Moving on to part 2, Snoop 4, spotting red flags. We're shifting from those manageable primary headaches to secondary headaches, which are symptoms of a much more sinister underlying problem that needs urgent evaluation. Whenever we evaluate a headache, we are constantly on the hunt for red flags. These are our absolute non-negotiables in triage. If any of these criteria are met, we do not just tell the family to go home and drink more water. No way. We escalate immediately. And the best way to remember these red flags is with a brilliant mnemonic, Snoop 4Y. Let's methodically break this down. S is for systemic signs, like a fever or a weird rash. N is for neurological signs, maybe an altered level of consciousness or a really stiff neck. The first O is onset, that is sudden and severe, like the worst headache of my life type of pain. The second O is onset during sleep or early morning, which is a classic sign of increased intracranial pressure. Then we have the P's. P1 is positional. Does it get worse when they lie down? P2 is precipitated by a Valsalva maneuver, so coughing or straining. P3 is a progressive pattern getting steadily worse. P4 is papilledema, swelling of the optic disc. And finally, Y is young age. Any severe headache in a child under 6 years old, that's an automatic red flag. Seriously, keep this list burned into your memory. Okay, let's execute a hard pivot here to part 3, drowning, a respiratory emergency. The formal definition here is actually vital to understand.
Drowning is a process of respiratory impairment from submersion or immersion in liquid. Notice how it doesn't say ocean or deep swimming pool. It just says liquid. An infant can literally drown in a bathtub, and a toddler can drown by just falling headfirst into a mop bucket. It only takes a few inches. And the absolute most important word in this definition is respiratory. Drowning is primarily a respiratory event, not a cardiac one.
Let's look at why that is. The fatal pathophysiological cascade starts with submersion, right? That leads to panic and breath holding, which is quickly followed by laryngospasm, where the vocal cords just completely clamp shut. This causes profound hypoxia, a massive lack of oxygen. If water is aspirated, it washes out the surfactant in the lungs, leading to pulmonary edema. Only at the very end of this sequence, if the hypoxia just keeps persisting, do you finally see cardiac arrest. Cardiac arrest is a late, secondary event here. The true root of the dying process is simply the lack of oxygen.
Which brings us to this terrifying number, 4 to 6 minutes. That is literally all it takes. While the heart and lungs can sometimes tolerate up to 30 minutes without oxygen, the neurons in the brain sustain irreversible anoxic damage in just 4 to 6 minutes. This tiny timeline is what dictates a survivor's long-term prognosis. It is an incredibly narrow window where rapid intervention means the difference between a full recovery and a completely devastating brain injury. Now, often, these submersions happen in cold water, right? Bringing hypothermia into play. And hypothermia has this fascinating dual effect. On one hand, cold water triggers the diving reflex, shunting blood straight to the brain and heart, and actually decreases the brain's metabolic demand, which is kind of protective. But on the flip side, prolonged cold exposure rapidly destroys coordination and muscle strength. It accelerates the child's physical exhaustion and ultimately causes loss of consciousness, sending them under the water way faster.
Part 4. Resuscitation priorities in drowning. Understanding that pathophysiology we just talked about totally dictates our emergency management when seconds count.
Because the primary mechanism of death is respiratory, and the greatest risk is anoxic brain injury, airway and breathing are your absolute top priorities. We really have to shatter the Hollywood myth here. You see it in movies all the time, right? Someone is pulled from the water and the hero immediately starts pounding on their chest. No. In drowning, the lungs are absolutely starving for oxygen. You must establish an airway and deliver rescue breaths first to reverse that fatal hypoxia cascade. And this next distinction is a total game changer in the real world. In a typical sudden cardiac arrest in an adult, getting an AED on the chest is priority number 1. But in a pediatric drowning, high-quality CPR with rescue breaths takes absolute precedence. Why? Because the heart stopped secondary to a lack of oxygen, not an electrical misfire. You have to oxygenate the blood. And practically speaking, you have to dry the chest before applying AED pads anyway, so do not interrupt your airway management to fumble with a machine right off the bat.
I need you to hear this clearly. Begin CPR immediately. Do not delay to search for a pulse. In an unconscious, non-breathing child pulled from the water, their pulse is going to be incredibly difficult to find anyway. They're probably bradycardic. Their peripheral vessels are totally clamped down from the cold. If you spend a minute feeling around for a pulse that might not even be there, that is a full minute of brain tissue dying. Do not wait. Do not delay. Just begin CPR immediately.
But what if the child coughs up some water and seems totally fine? Well, here is your strict warning. Symptoms can actually appear up to 24 hours later. That aspirated water can cause delayed pulmonary edema and severe respiratory distress hours after the event. A kid who looks okay right after being pulled out is absolutely not out of the woods. If they required any level of resuscitation, even just a couple of rescue breaths, they must be transported to a hospital for observation. Never, ever just send them home.
So the absolutely crucial point of all of this is, in a pediatric emergency, seconds literally save brain tissue. From recognizing those subtle Snoop 4Y red flags of a secondary headache to instantly prioritizing the airway in a drowning victim, your knowledge is what dictates the outcome. So the question is, are you ready to act? Thank you so much for joining me for this explainer today. Stay focused, keep learning, and I'll catch you next time.